everybody. Dave Robertson here. My job is just to introduce the seminar and the seminar speaker, who is James Liley today from Edinburgh. And he's going to talk about predicting emergency admissions in Scotland. Take it away, James. It'll be about 45 minutes, and then we'll have a chance to ask questions at the end.
Brilliant. Thanks very much, Dave and Serena. I'll just share my screen here. Right, so good afternoon, everybody, and thanks very much for coming along. So I'm James. I'm a postdoc at the University of Edinburgh and the Alan Turing Institute. And as the title suggests, I work on the large-scale prediction of emergency hospital admissions in the Scottish population. I've somewhat ominously titled this talk "Findings and Lessons Learned." Scotland's something of a world leader in having data available at this scale, and as such, we've done a fair bit of feeling our way. So it's my hope that, as well as discussing what we've done and found, I can also point others trying to do this sort of thing to the kind of roadblocks they might encounter. So this talk will be in 3 parts, and each will be something of a whirlwind tour over a lot of material. So firstly, I'm going to talk about the SPARRA project, a long-term initiative by the Scottish National Health Service to predict emergency admissions on the basis of electronic health records. To those of the Hibernian persuasion, I'm told this is a homonym for Sparrow, but it doesn't quite work with my New Zealand vowels, so SPARRA it will have to be. I'll discuss the history of the project, how we've approached it, and what we did. This led us to some insights into the epidemiology of emergency admission in Scotland, which we'll also cover. Secondly, I'm going to go into a grittier section covering how this type of research can be done, or rather the difficulties imposed by the need to do this in a secure environment, and how we manage those difficulties. Finally, in moving towards this future, I'll discuss a contemporary problem we came across and the generic theory of updating predictive scores. So this section will be more theoretical and depart from the discussion of emergencies and practicalities to more abstract ideas. This is necessary since I'm talking about a problem in this section we haven't actually encountered yet, but we will encounter further down the line. So each of these sections is somewhat independent of the others, so please feel free to zone out and zone back in when we get to the one you're interested in. I'll summarize each section as we go. So all of the real world results presented in this talk, so anything involving Scottish electronic health records, have been cleared for public release, but not peer reviewed or published yet. So please feel free to share them, but do so with the caveat that they're not yet definitive. At times in this talk, I'll discuss formal mathematical results, but it would be unnecessarily laborious to fully introduce the notation necessary to describe them precisely. So I'll just use rough descriptions. And so this talk will be about 45 minutes, which I recognize as a long time. So if anything doesn't make sense, please do interrupt or just pop a question in the chat. There will be an extended discussion at the end, but also please feel free to ask questions at the end of each section. So here we go. The KERR report, commissioned by NHS Scotland in 2005, made a series of recommendations as to what was seen as the future of the NHS in Scotland. So amongst these was calling for an integrated effort in preventative health, in particular preventing medical emergencies. So there's good reason for this motive. An emergency indicates a transition from primary preventative healthcare to secondary curative care. And more importantly, admission to an emergency department corresponds to a breakdown of health at an individual level. So we could hope then that reducing admissions to emergency departments is a reasonable target in healthcare planning, both from the perspective of individual health and for reducing overall costs to the healthcare system. The Sparrow project was founded in 2006 to address the same. For a given patient in a given time, it estimates the probability that they will have an emergency admission to a Scottish hospital in the subsequent year. So the earliest version of Sparrow was computed on only the highest risk individuals, relatively elderly individuals with a previous emergency admission, covering only a small percentage of the population. The second version, a little bit later on, extended this to individuals of any age with some previous emergency admission, covering about 13%. The current version, Sparrow version 3, has reached 80% of the Scottish population, about as many as we can. That's any age and anyone with a previous contact with the healthcare system. There's a couple of really remarkable things about the Sparrow project. So firstly, it covers almost the entire population of Scotland, all 4 million people. And secondly, it's actually already in use. And quite unusually for this, Sparrow is actually computed centrally for the entirety of Scotland and then deployed to GPs around the country for the patients in their care. So a GP with a patient, Mr. X, might see, for instance, that They've got a score of 40%, which is interpretable as they have a 40% chance of emergency admission in the coming year. So we're developing Sparrow version 4. So like version 3, it'll reach 80% of the Scottish population, and like version 3, it'll also be sent to Scottish GPs. A sample in our data is an individual and time pair. The times are one of 7 6-monthly intervals we're using for training data, and individuals are effectively the entire Scottish population. So our data come from a range of sources. These include A&E records, outpatients, mental health inpatients, hospital inpatients, and a couple of others, things like geriatrics and a systematic record, as well as prescription data. These show the distribution of age and sex over each over each input variable. The kind of covariates or predictors we are able to calculate, so some examples are things like the time since the last emergency admission, if there's been one, the number of prescriptions filled by a patient at a given time, and their deprivation, the deprivation of the area they live in. There's also a few things which are known to predict emergency admissions reasonably well, which we can't extract from routine health records in Scotland. These are things like number of engagements with primary care and other health determinants like smoking, smoking status or marital status. I should say I'll use the terms covariate and predictor incorrectly, but interchangeably in this talk, so just take them to meaning something we use to make predictions. So our target, that is what we're trying to predict, is whether an emergency admission occurred for that individual in the 1 year following the time cutoff, or that that patient died. If the patient, if the patient died in that year, we count that as an admission. These plots from the Scottish NHS show that emergency admission frequency varies by time, by day of the week, and by time of the year. And it's important to note that because we're using a year's worth of emergency admission, we average out all of these individual effects. Our rationale for coding death as analogous to an emergency admission was that for most people, if they're in mortal peril, we will try and admit them to hospital before they're dying if it were possible to do that in time. This is not necessarily true especially for elderly, frail people who may not be admitted. But we decided that in that case, Sparrow is unlikely to modulate their care very much. So the existing Sparrow v3 model begins by partitioning people into 4 cohorts. Firstly, a group of individuals over 75, a younger cohort in general, a younger cohort who's had previous emergency admissions, and a pediatric cohort. Each of these mapped to a design matrix where we generate covariates, and then a logistic regression model is fitted to each of these separately. We then determine the final Sparrow v3 score, so the existing score, according to whichever cohort this individual is in. I'm not going to go into a great amount of detail on exactly how we fitted version 4, but this is its basic structure. So we begin by using an unsupervised machine learning method called latent Dirichlet allocation to reduce the massive amount of prescription data we have into a usable volume, along with some information on diagnoses. We then assemble our predictors into an overall design matrix for everybody. And then we feed this through 5 major machine learning methods and combine these into an ensemble model, which we then use for prediction. An obvious question is, why do we make this so complicated? Why don't we just use one of these methods, the best performing one? So one reason is that we combine these models in such a way that, in theory, asymptotically at least, the linear combination will outperform the best performing model. Another subtly important reason is that the models can fail in slightly different ways. So if say we accidentally entered an individual's age as 700 rather than 70, we can imagine this would trip up a linear model which multiplies age by a constant and adds it to the score, whereas it wouldn't bother a tree-based model. So in a sense, these models can compensate for errors in each other. Because this model will only be used in Scotland, we're not too concerned about generalizability. So we're not really too worried about robustness to the demographics of the underlying population. Because of this, we can estimate the performance of the model using cross-validation on the data we have. So we divided the data into 3 parts and roughly fitted our score to 2/3 of the data at a time and evaluated it on the final third. It isn't important to go over this slide in detail, other than to note that firstly, cross-validation is quite complicated in this setting with our ensemble model and the unsupervised and supervised methods. And secondly, just to note that we keep the test portion of the data completely separate from the rest at all stages, including the fitting of the topic model. So we use two general metrics for assessing how well the model was fitted. Firstly, receiver operator characteristic curves. I'm assuming that most people here will be familiar with these, but for those that aren't, the main thing is that the further this curve moves away from the XY line, the better the predictor. We use the area under the curve to assess how far away it is. We can also interpret the area under an ROC curve as an estimate of the probability that given two people, X and Y, if Y is genuinely at a higher risk of emergency admission than X, then the score of Y will be higher than the score for X. An important thing to remember about the ROC curves, it only looks at where predictions are relative to each other, so who's higher than the other rather than absolute score values. So we could divide all of our scores by 10, and that'll be wildly inaccurate, but we get exactly the same ROC curve. So we also use a second type of plot called calibration or a reliability diagram, which measures how accurate our scores actually are. So what this says that if we look at everyone who has a score of say 0.4 or 40%, how many of them are actually admitted? In this case, maybe 25%. These aren't real plots. So it essentially tests whether the predictions are correct. A downside is it doesn't really care how much information is in the scores. So, I mean, in Scotland, the probability of having an emergency admission at any time is about, well, the probability of any of us having an emergency admission in the next year is about 0.8. And if we just assigned everybody in Scotland a score of 0.8 or 8%, then we'd be perfectly calibrated, but our score would be useless. So we do need to use both plots together. So our overall results are shown here. Version 4 is the red line, version 3 the blue. And we can see that version 4 outperforms version 3. The difference looks pretty modest in this plot, but we'll see in a minute that on the scale we're working on, this difference is actually pretty substantial, and especially in terms of the margins we're trying to beat. We can also see that the new model, version 4, is somewhat better calibrated, and that the calibration curve, the red line, lies pretty much right along the XY line. So this means that if we say the score is 0.2 or 0.4, then that genuinely represents the risk that person will have an admission. We can see differences a bit more clearly if we look at high and low risk individuals. So firstly, if we restrict our attention to individuals over 80 who are more likely to have an admission, we can see the margins between version 4 and version 3 are greater. It's also true if we look at low risk individuals, so people between 20 and 70 with no previous admissions. This suggests that there's a body of individuals at medium risk whose risk is fairly easy to estimate, and version 3 was doing a perfectly good job, and there's not really much margin for improvement. It's important to realize we can't predict emergency admissions perfectly. There's always going to be an element of randomness. Somebody's going to have a car crash, so they're going to get ill. So these suggest that we're kind of pushing towards as well as we can do with the variables we have. So these plots show the plot on the right shows a density plot of version 3 and version 4 for the same individuals. And it's quite instructive in a sense. So what we can see is that, well, what this plot shows is that generally version 4 scores are slightly higher than version 3 scores for many individuals. And in particular, there's a cloud of points down here of individuals who had a version 3 score of say 10 or 20%, but version 4 assigned them a much higher risk of 50 to 60%. We analyzed which was actually correct in this case. This plot on the left shows a comparison of calibration, so the accuracy of the score, for patients for whom the version 3 and version 4 scores substantially differed. And what it shows is that version 4 was generally correct when the scores disagreed. So these red lines show version 4 for people whose version 3 and version 4 scores differed. We can see they're closer to the XY line than the blue lines, which represent version 3. So we're generally, when the scores disagree, version 4 is more correct. So although the differences in the ROC curves before overall seem modest, on the scale of the Scottish population, this translates to quite a big difference in real performance. So if we consider the 20,000 patients in Scotland with the highest version 3 and version 4 scores, we would hope that we've identified a lot of people who were eventually admitted. So it turns out that with even this apparently small improvement in performance, using V4 over V3 means that among these 20,000 people, we find some 2,000 more we find something like an additional 2,000 patients who were actually admitted compared to version 3. So put another way, if we were to use SPARRA scores to bring to GPs' attention the 1% of the Scottish population most likely to have an admission, V4 would mean that we can potentially identify more than 3,000 at-risk people than would version 3. In terms of a number needed to treat, using version 4 means we need to check several thousand fewer patients for each 1,000 avoidable admissions. An important takeaway from these plots, and I think for this kind of project in general, is that on the scale of essentially the whole population, any little mathematical thing we can do to slightly improve performance has a big real-life effect. We had around 3 million people who were in the data set and who had data for about 3 years continuously. And we tracked how their scores changed over time, and we found something slightly surprising. As a whole, the risk of admission in these people tends to increase throughout the time period. This is expected as they're all getting older. However, if we look at those who are at highest risk at the earliest time point, we found that their risk actually decreased with time, dropping back down towards normal. So this means those at the highest risk tend to be there temporarily, and over time their risk will drop again. This plot is analogous to the previous one, but this time it shows scores for people at time points a year apart. And again, it's quite instructive. So for instance, for somebody with a score of 0.2, 20%, this vertical line would show the distribution of their score over the next year. So we see that most people stay about the same, but a few will jump up substantially from sort of less than 20% will jump up to 60 or 70%. However, if somebody starts at 60 or 70%, their score will tend to drop a bit the next year. So high scores tend to be transient. We took a look at the type of admissions we were successfully predicting. So what this plot shows is the distribution of scores over each cause of admission. The black dots show the average score for each cause. So we were generally very good at predicting endocrine and metabolic types of admission. This includes things like diabetic crises. We were less good at, we were also good at predicting things like cancer and respiratory issues. We were less good at predicting admissions related to skin, eye or ear problems or external causes of admission. So this is somewhat unsurprising, as these will tend to be things like car crashes, trauma, unexpected events. We can't predict them so easily. We're quite good at predicting neonatal admissions, and it's clear from this plot that most neonates have a fairly similar score. And this is unsurprising, as neonates don't have any medical history, and we're pretty much assigning them a high score based on their very young age alone. Correspondingly, we're also fairly poor at predicting obstetric admissions. This is probably because we have limited primary data in our data set, and generally we aren't able to preempt births. It's useful to consider how much certain covariates, for instance, age and deprivation, affect the risk score. This isn't a straightforward thing to do, and it sort of comes down to a consideration of how much information is available on each variable. So if we consider a variable like whether a person has had a diagnosis of epilepsy, it might tell us a lot about their emergency probability if they have been diagnosed with epilepsy. But if they haven't, but most people haven't. So on average, this variable, whether someone has epilepsy, won't tell us much. On the other hand, age doesn't tell us a great deal about emergency admission frequency, but there are many elderly and younger people. So on average, it tells us more. So we use Shapley values to characterize how much each variable contributed. Well, we use Shapley values to characterize how much each individual how much each individual variable contributes to each individual score. So they're calculated for each variable for each individual, and they correspond to how much that variable value corresponded to the individual score in an additive way. So for the epilepsy example, an individual with an epilepsy diagnosis would have a high Shapley value for that variable because it's contributed a lot of information. But somebody without an epilepsy diagnosis would have a score near 0 since it hasn't contributed much information. So these figures show the average Shapley value for age and deprivation for people of various ages and deprivation levels. So the way to interpret this plot, if you're 40, your age generally doesn't contribute much to your risk score. It's slightly protective, it's slightly negative, but it contributes more for elderly people and for the very young. The right panel shows the effect of the Scottish Index of Multiple Deprivation, a measure of regional poverty in Scotland. So roughly how wealthy or poor a suburb is. We can see that the more deprived a suburb, that is, the higher the SIMD number, the more being from that suburb contributes to worsen somebody's risk score. And the useful thing about Shapley values is these scores are comparable. So we can actually directly compare how much various variable values matter. So this plot shows an equivalence between the difference in Shapley values between the most and least deprived deciles of Scotland and difference in age. So roughly it shows that compared to the richest decile, the information that somebody is in the poorest decile in Scotland contributes as much to their risk score as much as 20 to 40 additional years of age, which is somewhat sobering. The left-hand plot can be thought of as adjusting in a sense for the other variables included in the SPARRA model. The difference is even starker when we don't adjust. If we just compare raw admission rates, this plot shows that individuals in Scotland's, well, in Scotland's most deprived 10% of areas who are 20 years old have admission rates comparable to those in the wealthiest decile who are about 65. So this is roughly the findings from the SPARRA portion of the talk. I suppose our principal finding is that emergency admissions can be predicted to a useful degree from routinely collected health data in Scotland. And this is important because it's more or less unprecedented to do this on a nationwide scale centrally. And we're only using things which are actually routinely collected by the healthcare system anyway. So we're not having to collect new data to do this. An important secondary finding is that contemporary machine learning methods and complicated methods can enable meaningfully more accurate prediction to a useful degree. And this is good to know. It's, I suppose there's a tendency to keep models as simple as possible, and this is maybe an argument in the other direction, that it can be good to use more complicated methods where available on this scale. We did find that different types of admissions can be predicted to a differential degree, and this is quite important for health planning in the sense that if we're looking at something like endocrine-related admissions, we know we can fairly accurately preempt how many of these are likely to occur. If we're looking at, say, eye and ear-related admissions, we're not quite so sure, so we need a bit more wiggle room in health funding. We had a look at how scores change over time, and we found that high scores are transient. Again, this is somewhat important. And finally, we highlighted again the importance of deprivation to emergency admission risk, which is again important for health planning. So after that, somewhat well of our results, I'll now come to the second part of the seminar. So Sparrow scores, as I mentioned, are deployed to each GP for the patients and their care. In order for GPs to have any confidence in the accuracy of the scores, we need to be assured that the scores we're sending out are the same as those in the paper. That is, reproducibility is totally paramount. In addition, Sparrow is completely paid for by the Scottish population, and it is used in a way which influences their healthcare. So this means we have an ethical obligation to be as open as possible in the way the score works, which again corresponds to reproducible and transparent practices. However, since Sparrow scores concern health data for the Scottish population, data security is paramount. So this necessitates doing all associated work in what's called a data safe haven, or a highly secure computing environment with tight control over its use. So in this part of the talk, I'll discuss some of the trade-offs between these needs, that is, reproducibility and transparency, and the difficulties we encounter in secure environments, and some of the ways we try to overcome these difficulties. So data safe havens protect confidential patient data in several ways, namely vetting individuals who can access the data, restricting what can be done to the data, ensuring that the safe haven is isolated from the internet, ensuring that data isn't identifiable, and close checking of anything that's removed. This makes reproducible research difficult for several reasons, which I'll run through over the next few slides. This project is additionally difficult due to its population-wide scale, the complicated process from raw data to results, and legal protections governing what can and must be done with it. So, taking a gold standard of reproducibility is the reproduction of results from the manuscript from raw data by independent researchers. We have to concede that this is not going to be possible in a safe haven context. Raw data generally can't leave the safe haven, and independent researchers can't generally access it. So, to overcome this, we took several steps. Firstly, we produced a deterministically generated mock-up data set, which resembled a subset of the real data as closely as possible. We used this to build a unit test checking our full pipeline, which can be extracted from the safe haven. So we can, although we can't extract the exact model, we can restrict all the code used to fit it And we can demonstrate this on a mock data set and demonstrate that the results from doing this are the same on and off the safe haven. We also made sure that as many of our real results as possible could be reproduced off the safe haven. So whenever we extracted a figure, we also restricted a minimal set of data needed to redraw it, as well as any of the code. We think this is probably a good protocol in general for reproducibility on safe havens. The second way in which safe havens can make reproducible research inevitably difficult is through restrictions on software and hardware. Firstly, since there's no access to the internet and associated resources, complex code often has to be written from scratch. And this increases the amount of new code, which increases the number of things to be checked. Software versions need to be fixed in exported software, and this can be managed with containerized output, but it's particularly pertinent because it's difficult to update software on DSHs. This means that any release tends to be out of date by the time it comes off. Because we don't have control over the machine, we can't control when it will go down, and we rely on other people to fix crashes. So this means, all of this basically means that general good coding practices are twice as important. Good garbage collection and checkpointing need to be employed, as well as careful commenting. Finally, the DSH works on a fixed machine structure, in our case, one Linux and one Windows machine, each able to run several necessary R packages, but with different versions of R. So it's not a computational structure we want to replicate off the safe haven. So our code has to be robust to major changes in machine architecture. So there isn't much we can do about this other than trying to ensure code will run sequentially and having it double checked by several people. Another important difficulty in reproducibility in this setting is the number of people of different backgrounds who take part in this project. This makes reproducibility difficult as we don't curate the entire raw data to output process ourselves. So as well as further hedging these difficulties with good coding practice, we've had to manage this by frequent interdisciplinary meetings and trying to keep everyone on the project up to date. Since this project will ultimately be deployed by Public Health Scotland, and a prerequisite for the reproducibility is that the people doing the reproducing understand the software, we've maintained a program of knowledge transfer in which we teach the relevant Public Health Scotland staff how the model works. And finally, and I genuinely think most importantly, working on a data safe haven is just generally difficult and slow. Every task we need to do is inflexible, needs to be more carefully vetted, and depends on more infrastructure than a typical offline project. The only way to really manage this is to put reproducibility and transparency at the forefront of research planning, which we've tried to do without this project. Without doing this, it could easily fall by the wayside, given the additional time pressures from working in this way. And I genuinely do think this is maybe the most important consideration that in trying to do research on this environment. It just takes 2 or 3 times as long as trying to do it anywhere else. So to briefly summarize this shorter section of the talk, the main lessons we've learned are that some aspects of this type of work lead to inevitable difficulties in reproducibility and transparency. Mock-up data sets are really useful, but they can be quite time-consuming and difficult to develop, so it's good to plan to do this early. And interdisciplinary communication is vital as ever. And yeah, again, possibly most importantly, since everything is more difficult, appropriate time has to be allocated in order to complete work properly. So finally, we come to section 3, which I think is possibly the most interesting part of the, well, which I hope is one of the more interesting parts of this talk. We're developing the 4th version of Sparrow. So this involves some complicated machine learning methods and is fitted on up-to-date-ish health data from around 2016. The first 2 versions of Sparrow were only on about 20% of the population, so we won't consider them too much. But the existing version of Sparrow, version 3, was fitted in about 2012. If we look at some patients in 2017, V3 seems to overestimate their risk, overestimate their risk of emergency admission. So this plot says that for certain patients, V3 said their risk was about 40%, but only 20% of them were actually admitted. So Sparrow V4 was closer to correct. Now, this isn't a very honest plot. This is our plot from before where the scores differ. I'm only using it as a demonstration here. In reality, Sparrow V4 estimates fairly accurately, but we expect that over time it will start to overestimate risk. And I suppose the important question is, why might it do this? Why might a score fitted in 2016 overestimate the risk of an emergency admission now? So one obvious potential reason that the healthcare system might have just improved, that we've got better in general at avoiding emergency admissions. This change in the system is called concept drift, and it has certainly occurred to some extent. But there's another possibility, which is more difficult and the central part of the section of the talk. It's possible that V3 is overestimating risk because it works. So suppose we have a patient, Homer Simpson in this case, who has an estimated emergency risk of 40%. His GP sees this, checks him up and reviews his care, reducing his risk to 20%. If we now look at how V3 was performing, it looks like it overestimated the risk. It said it was 40%, but amongst patients like Homer, it was only 20%. So it looks like V3 was getting it wrong when it was actually working perfectly. And it actually gets worse than this. From our perspective, our training data for V4 is now corrupted, in a sense. What we see is that a patient with these predictors has a 20% chance of emergency admission. These are the only things we see, when the risk is actually 40% if untreated, and so they're potentially in danger. So we can describe the situation more accurately using causal graphs, and I'm going to labor this a bit because I'll be using these to describe avoidance strategies later. In short, in a causal graph, an arrow goes from a bubble to another bubble if what's in the first bubble causes the second. When version 3 was trained, it was looking at what we might call the native healthcare system. So just, looking at just the native healthcare system, the only causal pathway from covariates to outcomes was the covariates themselves. So I've colored this system blue. When V4 was trained, however, there was an additional second causal pathway from covariates to outcome. As well as just seeing the covariates, GPs also saw the version 3 score and potentially changed their care as a result, in turn changing the chances of emergency admission. So V4 was covered to the system colored black here. If we simply put V4 in where V3 is now, as is here, then we're using V4 to make predictions on the blue system, which is different to the system to which it was trained. So a group of us, including Sam and Louis from Durham, Bilal from London, Seb from Warwick, and Catalina from Edinburgh, looked at this problem in detail with the aim of working out how serious it could be. And it turns out it can be pretty serious. Let's say Homer was on some horrible made-up drug called toxamycin, which raised his risk to 80%. So this is picked up by Sparrow version 3, and a worried doctor sees his risk is 80%, reviews him carefully, and drops his risk down to 10%. Now for version 4, it looks to us as though this horrible drug doesn't cause an increase in risk. This can mean we potentially divert people on this drug. For people on this drug who are in a high risk of emergency admission, we're potentially diverting important medical care away from them. And although we're still in the thought experiment phase, this is actually a big problem. Any new score used in healthcare should have a randomized control trial to back it up, which formally assesses its effect. Because of changing healthcare systems, concept drift, as I mentioned before, all scores need to be updated sometimes, and RCTs are really expensive. So the US FDA has proposed that predictive scores can go into use with only having one RCT at the time of their inception and be freely updated thereafter without needing to do more RCTs. In the light of the above, this is potentially quite a big problem. To make things even more inconvenient, it's pretty clear that the more the score is used, the worse this problem is going to get. If Sparrow scores are ignored, then we don't actually have this problem. But if doctors see Sparrow scores and care about them a lot, then this problem gets quite serious. Some nice work from Sam Emerson in Durham found that this effect means that scores which are better or more accurate can actually appear to perform worse. And this screws up our entire model comparison process because we can't assess how well scores are performing. So in short, this problem is potentially dangerous, and it's subtle enough that the US FDA didn't account for it. As far as we can tell, this issue was first raised by Leonard et al. In 2018, and that predictive models can be victims of their own success. The idea of predictions affecting their own accuracy has parallels elsewhere. So the Pygmalion effect in psychology finds that high expectations on students lead to the students actually doing well. So this also corresponds to this two causal pathways effect. A more familiar example might be vaccine hesitancy. So the extraordinary effect of vaccines in reducing communicable diseases, say diphtheria and measles, has meant that many people never encounter these diseases in the first place and do not see the effectiveness. So likewise, we get this two causal pathway thing, and vaccines are victims of their own success again. This is sometimes called performative prediction, coined in a seminal paper we'll come to in a moment. So what do we do about this? So my favorite approach when I come to a problem, as I'm sure as everyone else's, is just to ignore it and hope for the best. So what do we do if we just update scores and don't worry about this effect at all? So thinking back to the previous example, what we can see is we're fitting V4, then we're using V4 on a system different to that which it was predicted. We then fit V5, say, and we use V5 on a system different to that on which it was fitted, and so on. What happens if we just ignore this? So this was addressed very nicely in a fantastic paper from Perdomo and colleagues in Stanford. Under various assumptions, which roughly include that we take a similar action in response to risk scores, if we repeatedly update the model in this way, then updated scores will approach a stable point in which they predict their own effect. So this is a good thing in a sense, because we don't get the discrepancy between what we say the risk is and what it actually turns out to be. But there are problems. So we found out in a recent paper in AI Stats that with only slight additional complications, it doesn't take much for these assumptions not to hold. And scores can readily end up flying around wildly instead of converging. So this could mean that for exactly the same patient, let's say Homer again, our version 10 of Sparrow score could say his risk was 80%, and our version 11 could say his risk was 10%, even though he's exactly the same person. I suppose another problem with this, when scores predict their own effect, is that it's quite hard to interpret. A score which predicts its own effect we interpret as the risk of emergency admission once you take the action suggested by the score itself. The most important reason why we don't necessarily want scores to be stable in this sense is it turns out it's not the best we can do. So this is a little complicated, I'm afraid, but so we know there are potential problems we went over before in updating models, and that we can divert resources away from the people who need them most. But what happens if we do reach the stable point when the score does actually predict its own effect? So let's go back to our example with Homer, and we'll remember this nasty drug bumps his risk up to 80%. If a GP sees this risk, they're going to take a drastic action and presumably swap that drug for another one, drop his risk down to 10%. Now, if we have a score which predicts its own effect, what's it going to say Homer's risk is? It's not going to say it's 80%, because then it would get it way wrong. The risk turns out to be 10%. It's also not going to say his risk would be 10%, because then the GP wouldn't do anything, and Homer's risk will actually be 80%. So again, it would get it wrong. A score which predicts its own effect will label Homer's risk score at about 45%. So it'll cause the GP to take a half-cocked, lackluster action, say reduce his dose of the drug rather than take him off it, which keeps his risk at 45%. However, it could have been 10%. And so this predict its own effect phenomenon isn't actually where we want to be. Moreover, none of this actually depends on the cost of the intervention. So we're not really optimal in any sense. So yeah, to reiterate, a score which predicts its own effect doesn't generally lead to an optimal outcome. So we really want a way to overcome this problem, to work around it, not just naively update scores. So in a previous paper, we suggested 3 major approaches which can be taken to this problem. So the first approach is to model everything more completely. So if we, including modeling any effects of the interventions. There have been several options explored for this, and some are very nice. There is a bit of a problem with this though. If we call x0 our covariates before an intervention and x1 our covariates after intervention, then mathematically we can't identify the function mapping x0 to x1 from just x0 and y given x1. So this is what we typically have in a machine learning setting. It doesn't matter how much data we have, we can't learn this function. So we can't infer the intervention just from the data we have. If we're going to use this method, we need to collect more data. A second option is appealingly simple. Since the problem comes from just using previous versions of the score, what if we just keep out a random portion of the population and don't use a score on them? We can then refit the score to these left out individuals and train a fresh updated score and use it as we like. Unfortunately, this means that whoever's in this group, these poor schmucks, miss out on any potential benefits of the score. A third option is to directly control what interventions are made on the basis of the predictive score. So if we know what is being done, we can easily model its effect. Unfortunately, these scores are usually used in complex settings, and in our case, we can't really tell GPs what to do. We do have some options, which I'll come to a bit later. So the simplest and possibly best solution to this problem is to just use a holdout set. So this part of the talk mostly comes from some very nice work from a master's student in Durham, Sami Haidar. Strictly what we do is fit V4, then send V4 out for most of the population, except for some small subset in grey here, for whom we don't tell GPs anything. We then retrain the model to just this subset, giving us V5 and so on. And what we can see is that now we're only ever using a model to predict exactly the same system to which it was fitted. So a critical question around this option, though, is how big should this holdout set be? Heuristically, if it's too small, we won't be able to train new models to be accurate because we're not going to have enough samples. But if it's really big, then a whole lot of people are going to miss out on benefits of the risk score. We showed that as a natural consequence of a few basic assumptions, all of which do generally hold this time, there is a single optimal holdout set size, strictly more than 0 and not including everyone, which minimizes total loss, which in this case is total loss to the healthcare system. And if we make the set bigger or smaller, the loss gets worse. The language used to formally describe the setting meant we could look at consequences in a bit more detail. We found that the value of this optimal holdout set size depends on a range of things which tend to differ substantially between different settings. So there's no real hard and fast rule. We shouldn't really say use 10% of the population for it or use 1,000 people for it or so on. For instance, this figure shows how the optimal holdout set size and total cost to the healthcare system changes as the baseline gets more accurate. So whatever is being done without the score. Unsurprisingly, as people get better and better at making predictions without the score, we need more and more people in the score in order to beat it. So the holdout set size gets larger. Moreover, we found that the total loss or cost tends to only go up linearly as the holdout set size increases, whereas it can rise much more quickly as it decreases. So it's generally better to err on more people in the holdout set size than less. Finally, we noticed that this minimum and loss around the holdout set size is generally quadratic. So we're fairly robust mathematically to slight changes in the system. So because a hard and fast rule isn't appropriate, we needed to develop some sort of way to determine what this optimal holdout set size might be. So we need to start by estimating the cost to the healthcare system in terms of errors in the model and the cost relative to having no model. So that means answering questions like, if we get the estimate wrong by this much, how much will we have to spend on healthcare to fix our mistake, and how much will it hurt a patient? We also need to estimate the cost of having no predictive score, which is easier. Finally, we need to estimate the learning curve for our predictive score, which is essentially how fast the model learns the system with an increasing number of samples. If we then model all this parametrically, we can then make a point estimate of the optimal holdout set size and guess its standard error by bootstrapping. So I'll spend the final part of this talk discussing a radically different approach again. So this comes back to the idea of actually specifying interventions in response to a score, rather than just fitting it and sending it out. So a huge advantage of doing things this way is that we can actually solve problems like how do we optimize distribution of medical care in the population so as to minimize emergency admissions. So a downside of many predictive risk scores fitted in the past 20 years is that we generally don't have any idea what to do with them. And we can't really tell GPs what to do. GPs spend 10 years training for a reason. We can't really second guess them. And we don't really want to commit to making anything like that, to doing anything like that. The GP actually knows the patient and all we see is a number. So the idea of the second option is, though, rather than telling GPs what to do, what if we just gave them instructions like, do whatever you would have done had you seen this SPARRA score? And this turns out to be quite a powerful idea. So the idea of stacked interventions uses the causal graph in a different way. We fit version 4 as usual to the black colored system. However, now we do something different. We give GPs both V3 and V4 scores and tell them, please act in response to the V3 score and then look at the V4 score, which is the new risk. So then act in response to that. We can then train V5 in response to this combined system and then give GPs the version 3, version 4, and version 5 scores with the usual instructions and carry on doing this. And we can see again that we're never using a predictive model to make predictions on a different system to that which it was fitted. In this sense, each score is an adjuvant to the last, rather than a replacement. This approach, although it's really complicated, turns out to have some really nice properties. So firstly, we only ever intervene by telling agents, so doctors in this case, to do what they would have done anyway. Secondly, we don't have any of the obscure, complicated meanings of scores. Each risk score is directly interpreted as the risk before or after a given intervention. We don't need to use a holdout set, so no one in the population misses out. But something really nice about this method is a mathematical observation that in many circumstances, this procedure will cause everyone to move towards the same equivocal risk, no matter what the values of their covariates are. And getting everyone to the same risk represents, in a sense, an optimal allocation of resources. It's a really good endpoint to aim for. And we can get to this optimal allocation without ever actually needing to know exactly what GPs are doing, other than assuming that it's well-intentioned. So formally, we can say that if GPs' actions are well-intentioned, so they don't make risk scores worse, and a couple of other reasonable regulatory conditions are satisfied, then the risk for an arbitrary individual almost converges as we keep fitting more risk scores. It doesn't quite converge, but it's close enough. That is, if we act on version 3, then version 4, then version 5, and so on, eventually we can pull everyone towards the same acceptable emergency risk. As well as people's risks stabilizing, we can also show that their covariates tend to stabilize to a standard distribution, which I won't go into great detail, but this finding is somewhat robust to inaccuracies in our model training and slight changes to assumptions and some drift in the underlying system. But we can get some insight into how it works by noticing that this whole system is kind of analogous to a biological feedback loop. If we take Homer again, and we take his risk, we can detect the change in his risk using our risk score. Us being the control center, we can then recommend an intervention to GPs, and then that can start to correct the risk. What the successive adjuvancy idea, what the stacked intervention idea allows us to do is to keep going around this loop. So we can keep going around and pull Homer's risk back to normal. So that's why it tends to pull everyone towards the same risk, and also why it's somewhat robust. So just to reiterate how we'd actually apply these problems in the Sparrow context, what are we actually going to do? So we could just ignore the problem and update things naively. It's probably not a big issue in the Sparrow context because we don't, the score at the moment doesn't govern interventions widely. However, it will become a serious problem if Sparrow becomes used more often. Using a holdout set is a possibility. That is, we choose a random part of the Scottish population and just not calculate their scores. This does have ethical issues though, because of course they'll miss out. Stacked interventions is a little bit more fanciful. Give GPs the version 3, version 4, and version 5 scores and so on, and tell them to act on each of them in succession. This is essentially what we're doing in this one-off case. We're giving GPs the maximum of the version 3 and version 4 scores and asking them to act on that. So we have some ongoing work in this area. We're carrying on with the holdout set idea and we'll aim to publish this in a few months, and ongoing with stacked interventions as well. Some excellent collaborators in Warwick, Seb and Claudia, are using a modern field of machine learning called reinforcement learning to model these processes and work towards actually solving some of these optimization problems. So I think I'll end on a half-remembered paraphrased quote from David Sontag at MIT, who in general, who said that the past couple of decades of machine learning, we've generally focused on how to predict things. And now we've got a big backlog of work on what we actually do with those predictions. So I think it's important to think about that. So the important takeaway from this part of the talk is that this problem does actually matter. We do need to think about it. Risk scores do need to be updated, and the baseline simplest way to do this really does lead to problems. Sometimes it's appropriate just to update the model naively, but it can lead to unnecessarily complications, and it doesn't lead to an optimal outcome. I think the holdout set is probably the safest and best option for model updating. It's worth trying to find the best size for each individual study. And this should be done critically before the score is put in place. So that's why it's important to talk about this particular problem before we actually start seeing it, harkening back to the start of the talk there. Stacked interventions is a promising but weird approach, which has some really nice properties. It might be worth doing, even if we don't need to update the model, it might be worth doing just to get this equivocating effect. In any case, yeah, the most important lesson from studying these things is we need to get onto them early. And the fact that we haven't seen this yet is a good sign. It means we're not too late. So all of this work has been part of a semi-historic collaboration between the Alan Turing Institute and Public Health Scotland. And I would also at this stage like to thank HDA UK very much for a grant towards this project, particularly in the field of reproducibility, which has also led to some interesting work. There's a huge number of people to thank. Those in bold are those who are engaged in the updating work, but yeah, people from the University of Edinburgh, Alan Turing Institute, University of Warwick, Durham University, and particularly Public Health Scotland. So thank you very much, everybody. I'll take general questions now if there are any.
Great, thanks, James. That was very comprehensive. We have various questions in the chat. I noticed Emily Lamb waved though, which that's a good way of getting ahead of the queue. Emily, do you want to ask something? Why not?
Well, I have a danger of forgetting my question. As a layperson, I think the use of predictive scores might be a bit tricky for individual person. I can see the benefit on the collective planning scale, but if, say, for instance, people over rely on the predictive score, they might just run the danger of dismissing any vital changes, signs, and ignore good judgment. And so there's a patient safety that I'm interested in hearing from you.
That's an excellent point. Well, I'll say it's a point which has sort of received a lot of discussion in the past, well, in the past 20 years, I suppose, particularly around things like genetics, and partly in the opposite context, that people sometimes see their own scores and overreact rather than underreact. In our case, for SPARRA, it's not actually directly possible for people to see their own scores. The only way to do it would be to go through your GP and ask them. The reason for this is security. We can't have it. It's not really possible to have somebody look up their own score on the internet, say, and completely discount the chance of being able to look up somebody else's score as well. So in our case, these scores will essentially only reach individuals through the general practitioner. And I suppose we can generally hope that the GP will act appropriately. Nonetheless, that's a particularly vital problem for risk scores in general. And I suppose coming to the idea of model updating, yeah, it harkens back to this idea of it's very difficult to know what interventions are being done in response to the score. So if somebody sees the score themselves, we don't know what they're doing. Yeah, I hope that answers the question.
Good. So I'm gonna I don't know if you can see the chat, James, but just in case you can't in any way, for other people's benefit, I'll shout some of these out actually if I can. We'll try to rip through them quickly because you got a lot and lots of compliments on your talk actually, which was very clear. So one from Laura Cowley who says, is the Sparrow score used in clinical practice, and if so, in what settings? And are there plans for external validation or impact analysis for use in other countries?
That's an excellent question. So answering the second part first, there are similar scores have been developed in a slightly different way in England and Wales. I'm not sure about Northern Ireland. The reason they're not really transferred is because records are kept differently. So England keeps health records in a different way to Scotland, and in particular, I believe they're partly kept on a health district basis rather than, it's quite hard to organise scores nationally. So the reason these scores aren't, the reason we're not really looking to externally validate this internationally is because it's not really practical to do so. We can't generally reconstruct the same covariates. there's been papers on prediction of emergency admissions which have found that it's generally better to refit a model in a new circumstance rather than try and transfer an old one to it. So even if there was, say, only 10,000 training samples in a new country, it's better to refit a model using those rather than try and use a model fitted in a different country. And the first part of the question, oh, I'm sorry, where are we? Sorry, so is the Sparrow score used in clinical practice? It is. GPs can look it up, and they do use it. To some sense, we're telling people what they already know. It is, I suppose, the main area it's used in clinical practice is in healthcare planning by Public Health Scotland, especially estimating healthcare burdens.
Good. So Aidan Doherty was asking if you have any plans to do a health economic analysis on the cost savings.
That's it's in the long run plans. I suppose the first thing, yeah, we're planning to do an RCT on Sparrow eventually, which a health economic analysis will be part of that.
Mm-hmm. Good. So I'm ripping through these fast because you've got a lot of questions actually, which is a good sign. So next one is from Harriet McCann. Actually, she has several in one chat. So one is one sort of we covered a little bit. Any plans to move the approach outside of Scotland? You talked a little bit about that, I think. So next one is, why is only 80% of the population captured? What happened to the missing 20%?
Yep. So the missing 20%, it's another very good question actually, and one which we have thought about. It's 20%. It's not at random. So this includes individuals who haven't had any access to the healthcare, who haven't got any healthcare records. Essentially, we don't to the healthcare system. We're not sure they're there. This doesn't necessarily mean they're the healthiest communities. It also includes, for instance, things like traveller communities who may not contact the healthcare system much. So yeah, that the short answer is 80% because we can't get to the other 20%. And the second part, what direct interactions with GPs have the project team had? We've collaborated with GPs through this project. I don't know if my acknowledgement slide is still there, but we're very grateful to Keith, who's a GP in Ayrshire, who's also doing a PhD at St Andrews, who's been helping out through this entire thing. Earlier in the sorry, yeah.
Carry on. I thought you'd finished, but you carry on.
Oh, earlier in the project, there were consultation sessions with GPs around the country.
So I was going to say, Carol Fogg's question, which comes up next in the list, I think links into this. So basically, it's how do the GPs interact with the scores?
Yeah, and are they available to review? I know they're available. Public Health Scotland has them. I'm not sure if previous scores are available to GPs or whether the most recent score is the only one.
Oh, and next one's a technical one from Holly Tibble, which you can read while you're reading. I'll read out loud for everybody else. So, could the issues with changing the care based on the predicted risk not be averted by including the facets of the care that have changed in the model's predictors and then updating the risk care changes?
Yeah, that's a very good question. That's essentially the first solution I mentioned in the problem. So if we, well, I'm giving a technical answer to a technical question. If we call X naught our covariates before any intervention has happened, we calculate the risk score based on X naught, deploy the risk score to act as GPs in this case who act on it, and change the covariates from X naught to X1. And then X1 determines the outcome. So we're trying to map this X1 to outcome function using an X0 to outcome observation. And that's kind of the core of the problem. We can't see X1. We generally assume it's something we can't observe. And why given X0 as a counterfactual, we also can't observe. So the difficulty with doing it this way is we'd need to re-observe covariates after intervention. And we generally assume we can't do that. But very good question.
Next one's an interesting one. So from Sophie Staniszewska, if I pronounced that correctly. I'm terrible at pronunciation. So she says our PPI group are interested in identifying ways in which public contributors could contribute to Sparrow. So if you wind it out, it'd be great to discuss the potential for active forms of public involvement to co-produce some of the thinking. I don't know. Is there potential for that? I don't know.
I agree. So at the moment, most of the involvement has been at the GP level. I suppose, yeah, we are hoping to expand direct public involvement as well.
Okay, so next one is from Javiria Lenitz. So could it be that prediction changed because of changes in healthcare infrastructure, bed availability, stuff like that?
Absolutely. So this is concept drift, it's called. And this is the reason predictive scores need to be updated in the first place. The healthcare system changes. And it's a difficult thing to deal with. So, I mean, if it weren't for concept drift, we could just fit a really good model and keep it in place for perpetuity. And I suppose one of the real difficulties with the score updating thing is if we see that the previous model overestimated risk, we don't know if it's concept drift or if it was working.
Yeah, I think that's what that question was edging towards. Yeah, it could be loads of things in the environment that you aren't necessarily able to predict. Right, I'm back to Laura Cowley though. Lots of doctors mistrust or don't use predictive scores, so can't tell whether the intervention was necessary but not given.
Yeah, this again comes down to the fact that interventions are very hard to model and very hard to infer.
And sorry, I'm trying to. There's a comment here from Andrew Keane, which is lengthy. I'm trying to get it into my mind. I could just read it. Let me see. Maybe you can pick it up faster than I can, James.
I think the. I'm sorry, I'm speed reading this, Andrew, but I think the gist of it is that intervention isn't consistent across GPs, and depending on resources and guidelines, as you've also said, which I presume, yeah, it changes across GP practices and changes across time. So yeah, it's a very good point. This comes down to the way we're addressing this at the moment by modeling it as a random variable. So the intervention is random to some extent. Well, we model it as random to some extent, where the idea is the randomness accounts for the variation in how interventions are made. And you've also alluded to the cost, to depending on cost. It's another excellent point and it would merit a much longer answer than this. But yeah, I suppose a large part of this is trying to work out how to allocate interventions for a particular fixed total cost.
No, I think Aidan down below was joining in that conversation. If you go down to the next one about introducing
randomized control trial. Definitely agree.
Right. Okay. And wow. Let me see. Oh, all the rest you'll be happy to hear, Jay. All the rest seem to be entirely complimentary. Basically, they aren't really questions. Nobody ever puts anything like that into my talk. I can tell you that.
Well, thank you very much, everybody, for coming and for the introduction, Dave.
My pleasure. My pleasure. That worked very well. You'll see the message from Serena. The next one is going to be Kasper Sokol on creating diverse interactive research outputs from a single source by extending the Jupyter ecosystem. That's on Tuesday, the 12th of October at 3 o'clock on the same channel, Zoom. And there's a registration link if you want to find it in the chat. So I think that's it. We're a little bit over time, but it's nice to have so many questions. So I hope you don't mind. Thanks for turning up. This is a very thriving seminar series now, and see you in October. Thanks, folks, and thanks again, James.
Thank you. Thank you, James. Thanks, Aidan.